it. So you can go ahead and turn there now. I'm going to start with going over a few definitions, kind of a little introduction. A lot of this stuff you've already at least been introduced to in lecture, which is good. It'll help with the bicarbonate buffering equation and some level of chemistry that we don't usually deal with, but is really important because it's easily the most important chemical equation in biology. We'll get to that at the end. We'll try to take into account kind of how this is happening in the body, why we use this, because it is a really complex thing. You won't fully understand it today, but I really do encourage you to try to understand the last topic we talk about today before you finish this course, because you'll encounter it again, and the more sense it makes to you now, the easier it will be in the future when you have to deal with this again, and you will. You'll deal with the bicarbonate buffering equation and real life applications of it constantly. But first, let's just talk about how we breathe and go through a few definitions. So let's take a look at, we'll stick with a little bit of anatomy first. So pulmonary ventilation, I'm just starting from top to bottom on page 5 here. So pulmonary ventilation, that's just breathing, basically. That's a fancy term for breathing. And so we all know we breathe. Breathing's unique because it's voluntary. Not entirely voluntary, but mostly voluntary. So it's a unique vital sign because it is considered a vital sign, your respiratory rate, how frequently you breathe per minute. But it's not like your heart where you don't have direct control over it. You do have direct control of breathing. So respiratory rate is a difficult one. It's a difficult one to measure on patients unless you have something attached to them that will actually tell when your chest gets bigger and smaller. From just looking at someone, it's very hard to tell how frequently they're breathing. When you are taught formally how to take blood pressure, they'll probably be like, oh yeah, and take their respiratory rate at the exact same time. It sounds great. It sounds super easy, but it's not. Because they might change within that 30 seconds that you're taking blood pressure. So it's a hard thing to do. But what's even more interesting, I think, besides that voluntary component of respiration, and it's voluntary. The reason it's only partially voluntary is obviously you can't just hold your breath forever. Your body will eventually override your voluntary control and make you breathe. The second thing is you can also demand so much from your body, like a really high intensity physical activity, where your body, again, takes control of your voluntary ability. You can't stop. You're just sucking wind and there's nothing you can do about it. And so it's partially voluntary. But the way that we breathe is really weird. We do not pull on our lungs with muscles using tendons. Every other motion that we have in our body that we're familiar with experiencing has a muscle creating the mechanical work and then some kind of tendon or connective tissue inserting on the thing that's moving. That's not how the lungs work. There are no tendons from the diaphragm into the lungs. Instead, there is a vacuum around the actual lungs. And the consequence of there being a vacuum, and a vacuum, not like a vacuum, like lack of air. There's a lack of air, like a vacuum of space type vacuum. And so this is this intrapleural pressure here. So you have a very low pressure. It's not a true vacuum. There's not no air in it. But you have a lining around your lungs above the visceral pleura, but inside of the parietal pleura in a space called the pleural cavity. So very similar to the heart, where you had a pericardial cavity with serous fluid in it. With your lungs, you have a cavity that doesn't have really anything in it. There sometimes gets a little bit of fluid in there for a little bit of lubrication, but for the most part, it is a closed area that air cannot get into and cannot get out of. And that's really important because the way we breathe, we do move muscles, but instead of inserting via a tendon, we use changes in air pressure to create a situation in the lungs where air must flow in. So they always use this little model. This is a lung model, very simple. And it's kind of obvious what the lungs are. They're the balloons inside. You've got your trachea and your primary bronchi going into them. But what they've done is this space inside, where the white is here, they've made it much bigger. They've overrepresented that space. So now this is our parietal pleura. The visceral pleura, I suppose, are kind of what would be wrapping around the balloons, and the space in between is now way bigger than it is in reality. But the concept's the same. It's a totally closed space. This is tight enough that no air can come in this way. There's no holes in the plastic, so it's totally closed. The volume of air, the molecules of air, I should be very specific in this description. The number of molecules of air in here will not change. But what you can change is the actual size of this area. Now there's a couple different ways you can raise your rib cage like this. Chest breathing, sort of, like when you need to breathe a really, really deep breath and expand them as most as possible. But for learning this in the first place, I think it's easiest just to think of your primary inspiratory muscle, which is the diaphragm, doing this. So when your diaphragm constricts, it actually, now it's not flat like this. This model is not accurate that way. Just like the picture shows, it actually arcs upwards. Your liver is under here. But when it contracts, it actually goes down. So it's like a big dome that you're collapsing by adding tension to it. But it's going to increase the volume of the space around your lungs without letting air flow in. And what that does is it drops the pressure. And when the pressure around these balloons decrease, the air will be forced to rush in towards that low pressure in the balloon and fill your lungs. And so as I pull down, the hissing is coming through the cork, air's moving in from the atmosphere into the lungs and filling the lungs. I don't have to physically touch the balloons. And then the opposite is true. As I push up, air is forced out because by shrinking the volume around your lungs, you increase the pressure in your lungs, and air will always move from high pressure to low pressure. That's just the rules of physics in any type of fluid. Where there is a high pressure and a low pressure, things will always go from high to low. So our goal with the lungs is during inspiration, we want to create low pressure in the lungs so that air will move from the atmosphere into the lower pressure lungs. The way we do that again is by expanding the volume, and they inflate. So the way we do that, our diaphragm, so when you're belly breathing, trying to keep your rib cage stable and just kind of pushing out your stomach, oh man, I'm really full. I didn't feel very good. So the diaphragm's over the stomach, and I scarfed down a really big burrito at lunch. And so my diaphragm literally just ran into my stomach. And so it's a little uncomfortable. So I'm going to be more likely, now that I'm full, to use other respiratory muscles, mostly your sternocleidomastoid, your external intercostals, your pectoralis minor, and your serratus anterior. Those are what are called the secondary muscles of respiration. And so those, instead of pushing down on my stomach to increase the volume around my lungs so I can breathe in, they lift my rib cage. So this model doesn't really show that. This is like a diaphragm model. But if I were to have a flexible thing here and pull up on it and increase the volume in here, that's kind of what I'm doing with my lungs. I'm literally leaning back, expanding the rib cage, lowering the pressure in my lungs. That way air goes into my mouth. So we're not sucking, we don't have a turbine in our lungs pulling air in. We don't have tendons in there. It's all this pressure relationship, and it's unique, especially inspiration. Because I can't think of very many practical ways that we ever see this, where you lower the pressure around something in order to inflate it. Can anybody think of anything like that? Really bizarre thing to do.
That model?
This model, yes. Normally, what do? When we want to fill something up with air, we get an electric pump or a foot pump like an air mattress, right? You boost the pressure outside by compression and pump the bed up or something like that. We don't do that with our lungs. The breathing out is a little bit more intuitive because we do this often. We do often have things with fluid inside of them or something inside of them that we squeeze, and then stuff comes out, like a toothpaste roll. It's pretty common that you're going to squeeze something. So people don't struggle with the exhalation much, but the inhalation is weird. So spend some time on it. Make sure you know how to describe it in words. Statements like the pressure in the lungs drops during inspiration, so air moves into your lungs. And it's all based on that constant law of physics that always high pressure to low pressure. It's always going to move in that direction. That's why, and that applies to the weather, that applies to everything, right? So next time you watch the weather report, notice that the high pressure area and the low pressure, everything's moving from high to low. That's why high pressure, like we've had over the last couple of days, clears things out. Everything leaves. It's great. And so our lungs work in kind of a unique mechanism. So use this to try to understand that. The reason it's really clinically relevant is that our ribs tend to break sometimes. It's usually our fault. And they tend to break the plastic dome, right? So a rib, when it snaps, tends to break in a way that makes it quite sharp. It doesn't just get cut in half like you sawed it in half. It tends to splinter. And those splinters can fracture the parietal pleura, and if they create a hole there, now when you pull your diaphragm down, air has a way to fill the container, and you therefore can't create low pressure. You create a really small amount of pressure, and all of a sudden the air comes in here instead of being forced to come in your trachea. And so if the hole's big enough, your lung will partially collapse or potentially completely collapse depending on how big the hole is. And so this is a punctured lung. It doesn't necessarily mean you've actually broken the lung itself. You've broken the parietal or sometimes the visceral pleura around it, and now you can't breathe in that lung. Luckily, this lung is isolated in terms of pressure from this one. So you can have this one totally collapsed and have little to no effect on the other one, which is great because we only use about 5% of our lungs, so you're not going to die from a collapsed lung. But it is something that has to be dealt with. And so often the easiest way to fix it is just to cover up the hole. Right? I mean, it's pretty straightforward. All you got to do is patch the hole. And once you patch this hole, this lung would just collapse. And even when you would breathe in, it wouldn't inflate. Air would just run in and out through the hole you've created. But if you literally put your hand over it, if you can create a seal, you're probably bleeding too, and the blood really works to seal it off. It's like in The Martian. That's why his suit doesn't break. His blood seals off his suit. Has anybody seen The Martian? You guys read the book?
Nope.
The book's super cool. It's really easy to read. It's all his log, and they give you the details like that. But the reason his suit doesn't deflate is because he bleeds over the thing that's gone into his suit, and it seals it off from the atmosphere. Well, you can sort of do that with your hand and the coagulated blood, and if you do effectively seal it, you will then be able to inflate the lungs. So pretty straightforward, but foreign. It's a really foreign way to inflate and deflate things. So spend a little time with it. So I mentioned the muscles of inspiration. Also listed on your sheet are the muscles of expiration. And the first one is not a muscle, though. The first one is elastic recoil. So when I take this big breath using all of my accessory inspiratory muscles, I've built up a bunch of tension. I've stretched out my rib cage. So now when I just release that tension in my muscles, the elasticity of my rib cage and the connective tissue holding it together collapses. So there's not a whole lot of muscular work involved in the normal breathing every day. When you're just breathing, you're not usually blowing out with your rectus abdominis or your internal intercostals. So it says abdominal muscles, but it's mostly rectus abdominis. So anybody who's had a cough recently knows there's a certain group of muscles that get quite sore when you've had a cough. Rectus abdominis is one of them. You'll also feel like your ribs will actually feel like they're sore, but those are actually the internal intercostals. So that forced expiration, if you do it enough, you'll get sore just like any other muscle. And the next two terms are just atmospheric pressure and intrapulmonary pressure. So those are the two pressures that you're comparing, basically. Atmospheric pressure does not change significantly in any of these. So don't think that the atmospheric pressure is changing. What you're changing is the pressure in the lungs. So as you increase the volume, the pressure in the lungs decrease. And when pressure is lower here than it is here, air goes, like it always does, from high pressure to low pressure. When the pressure is greater here than it is out here, and you do that by constricting your rectus abdominis and your internal intercostals, then the pressure is higher here, and the air would run towards the relatively lower pressure in the atmosphere. And so that's basically how your inspiratory and expiratory muscle patterns work. They don't work through tendons, they don't work through anything like that. And so if you have something that punctures your lung, this whole system breaks down. But otherwise, if everything stays intact, it actually works really, really well. Very minimal maintenance, very minimal friction, because it's really an air pocket that's separating these two, so you're not really dealing with a whole lot of physical contact. But you can get inflammation. It's called pleuritis when you have either inflammation or fluid. If you have inflammation, you usually have fluid in there, so you can get some really awful pain in your lungs because of that type of pathology. All right, let's talk about sounds real quick. There are two sounds that you can listen to, and we have stethoscopes in the back if you want to listen to your own breathing or a partner's breathing. Bronchial sounds are the first kind. A lot of people are familiar with bronchial sounds. That's the wheezing. You know, if you have an asthma attack or some really nasty allergies that cause a little bit of an allergy-induced asthma or exercise-induced asthma, this is wheezing in our blue tubes that you see on the picture right here. So you're going to have some kind of constriction or narrowing in the smooth muscle. It's usually not crazy significant unless it's like anaphylactic shock or something like that. You're going to have wheezing and you're going to hear that. That's something you could even hear with your own ears. You wouldn't necessarily need a stethoscope, but to get a detailed idea of where that sound is coming from, a stethoscope will help you tell whether or not it's in a primary bronchus, secondary, or tertiary, because the sound of air moving through tubes is different based on the diameter of the tube. So as you do this more and more, you start to be able to be like, oh, this is pretty deep in the lungs, which would be a bad thing. You want everything that goes wrong with the lungs, the shallower, and by shallower I mean closer to the trachea, the better. The second one is vesicular sounds. Those are not audible. Hopefully, I'm sure someday you'll hear some ones that you can hear with your ears, because that would mean it's really bad. But for most people, most healthy individuals, your vesicular sounds are just the sounds of your alveoli expanding and collapsing. And so, even if we're perfectly quiet in a perfectly quiet room, we're not really going to hear this sound that's almost like saran wrap being pulled off of itself. It's kind of the best description. A little bit more popcorny than that. But it has an interesting sound to it, and it changes based on different pathologies. If there's like fibrotic tissue in there, there's going to be like cracking and popping rather than a little bit more smooth, wet sound. That's what you're hoping. You're hoping all those alveoli kind of relatively smoothly expand and collapse. And so those are your two basic categories of breathing sounds. All right, let's talk about respiratory volumes. So these are just diagrams taking a look at what I was talking about, collapsing and expanding. Notice the different shape of the rib cage on the left. Ooh, there to there. So you're actually flattening out. There's actually a remarkable amount of motion in the rib cage. And the more active you are, the more frequently you use all of your lung capacity, the better these muscles actually get at working. So breathing training is actually a big part, both in like athletic events, but also for patients that are struggling to breathe. You're going to see hypertrophy in some of these muscles. Most easily seen, these are deeper muscles, right? You're not going to see the diaphragm in someone unless they're in surgery. You won't really see the intercostals either. You might be able to feel them and tell their relative size. And someone who has really protruding ribs, they may look like they're starving, but sometimes it's because they haven't actually been using their intercostals as much, because they actually atrophy and get skinnier. So the ribs become more prominent. But it's they don't have a picture in this diagram. The sternocleidomastoid. So I always plug my nose to show you. Big sternocleidomastoids, right? There are these big muscles that run from your mastoid process down to your sternum and your clavicle. Sternum and clavicle, not sternum. Sternum, clavicle. And those are the ones you'll see on patients, and you can see how labored their breathing is and how long it's been that way. Someone who has like edema on the lungs is having trouble breathing, and it's only lasted a couple days, their neck's going to look normal. But if someone's dealt with this for a long time, they are going to have a hypertrophied sternocleidomastoid. And so it's an interesting thing that you will notice. You'll notice these huge muscles, especially relative to the rest of the muscles in the individual, that can give you some indication of how long someone's been dealing with breathing against a large resistance. All right, so you have a picture kind of like this in your book. It's a nice picture, but I think it lacks some necessary detail. So there is one picture in the PowerPoint that you probably should study. I like it better, and I'll walk you through each one of these, but normally I say, don't study the PowerPoint, but this is one that you probably should. So we're going to talk about each one of the volumes. I want you guys to know the numbers for these. In your book, you have numbers for males and females. I don't want you to remember I don't really like you guys to memorize numbers that much, because in almost every case, like blood panels and stuff we're going to be doing in urinalysis, you're going to have the reference point right next to whatever the patient's results are. However, I want you guys to have some kind of like real understanding of how big is 2,000 milliliters. Like I want you to be able to kind of picture that in your head. We don't often use milliliters, especially not that many, but that's a 2-liter pop bottle. Right? That's what 2,000 milliliters are. So I do want you to know the numbers listed in your packet. They are not universal. They're the averages for men. The averages in your book for women I do take somewhat of an issue with, because they don't control for body size in the averages. So if you look, there's women's and men's numbers. They look way different, as if women have way smaller lungs than men. They don't. They're just smaller people in general. So if you control for body mass, Women, yes, they do, like they have a smaller lung, they do have a little bit smaller lung, a little bit smaller hearts, but it's not all that relevant, really. And so I don't want you to walk out, I think it has like 3,100 for not vital capacity, probably for inspiratory reserve. For men, it's like 1,800 in women. That sounds like that's a little bit over-representing that difference. So all I really want you to know are the numbers written in your paper, and challenge yourself to like make these numbers intuitive so that you know what is 500 milliliters. What is that? That is a half a liter, and so it's not much. And that's a good thing to be able to take away because that's our tidal volume. So that's the first volume I want to talk about. Our tidal volume, remember we're tidal breathers, so we breathe in and breathe out, rather than in and out, or in, out, out. I don't know any animal that does that, but we're tidal breathers. We're just going in, out, And that normal resting tidal breathing, that's what tidal breathing is just a resting breathing rate, is around 500 milliliters. And this is pretty close in men and women. Body size is a big predictor of your lung size. And so bigger, taller people, and so let me be more specific, your height, not your body size. So someone my height that was much heavier than me would likely have the same size lungs as me. So it's your height is the biggest predictor of your lung volume. And so tidal volume does go up a little bit with height, but it's actually the most consistent number amongst all people is tidal volume. So that's just relaxed breathing. So you're not even thinking about it. It's actually a hard one to measure because if you ask someone to breathe normally, they start thinking about breathing. And they're like, is this normal? I don't know if it's normal. And they tend to breathe too much. So if you do this for someone, you're likely to get it. This is a good one to know that that's the norm because you don't want to write down like tidal breathing 1,100 milliliters and not catch that that's probably an erroneous measurement, that they maybe were just thinking about breathing too much. It might not be, but it also might be. So it's good. That 500 is a really good one to know. So that's your normal tidal volume. Then you can either breathe in or breathe out beyond that tidal volume. So your normal breathing, then you could take a way bigger breath in, or at the end of a normal exhalation, you could breathe out way more. So those are our next two volumes, inspiratory reserve and expiratory reserve. So this yellow arrow is for this curve right here. So this would be breathing in, breathing out normally down to this line, and then forcing the rest of the air you can never get out of your lungs. So good name, expiratory reserve. It's like the backup amount of air that you have in your lungs that you could get out all at once. Yeah.
What about getting the wind knocked out of you?
So wind knocked out of you, it causes spasm in your diaphragm. And it causes you to not be able to breathe in using your diaphragmatic muscles. You can still use your secondary muscles, but that's a great example of how important the diaphragm is in breathing. Because a lot of people are like, no, I breathe with these muscles up here. Just punch them in the stomach. And then they're like, wait, no, it's not. It's only little teeny tidal volumes that you could ever take with just using like your sternocleidomastoid. So it's good for maximum force, but it doesn't actually move the ribs that much. So you need that diaphragm. So inspiratory reserve, notice it's much larger. Right around 3,100, I think that's what your sheet says, inspiratory reserve.
Yeah.
3,100, so 3.1 liters. So that's a lot. Let's think of a 2-liter pop bottle plus, a little 1-liter bottle. That's quite a bit of volume that you can actually just hang out, can store up in your lungs. And it's way bigger than our inspiratory reserve. And that should make some sense as you start to think about the respiratory system, because holding your breath, especially for aquatic mammals, is a really, really important thing. And we evolved most likely from aquatic mammals, so we've retained this ability to hold our breath. And so seals and stuff like that can do some real fancy tricks, but we still retain this way bigger inspiratory reserve volume than we do expiratory. Because there's no benefit in being able to expire a large volume. That doesn't really help you. It's actually better to be able to expire small volumes more quickly. And as you get all the way through your respiratory material in lecture, that'll make a little more sense to you. That high frequency expiration is the most efficient way to rid yourself of CO2. That's why if someone has a panting like breathing that's not a dog, there's probably because they have metabolic acidosis of some kind, and they're trying to compensate for it by blowing off CO2 as fast as possible. They're not going to come in and do this. Takes too much time, is not as efficient for getting rid of CO2. So we really have no reason to be able to blow out huge volumes, but we do have sometimes, or at least previously in evolution, we had some reason to take in a huge volume. So those are your three most important volumes: inspiratory reserve, expiratory reserve, and tidal volume. We have one more in the yellow arrow before we move on to our capacities over here. This is called the residual volume. This is pretty cool, and this is also something to understand the size of. For most people, it's roughly about 1,000 and 1,200 milliliters. And this is what's left in your lungs after maximal exhalation. And it's not a trivial amount. It's actually quite a bit. So you have over a liter of air left in your lungs and your bronchi after you try your best to exhale air. And so this is important because it's important in the big concept of what the concentration of gases are in your lungs. So a lot of people think, okay, here's the air. It's about 20% oxygen. It's mostly nitrogen, which doesn't really matter to us. 20% oxygen, that's an important molecule. Very little CO2 out there. So basically no CO2, 20% oxygen. But if you take a little 500 milliliter little tidal inspiration, that air, that additional 500 milliliters, does have 20% oxygen and virtually zero CO2. But remember that this little tidal inspiration gets mixed in with the residual volume that's left over in your lungs. And so it's diluted out. So you don't have 20% oxygen in the lungs. You don't have that at all. It's much lower than that. And so the residual volume will remain about the same. But as you breathe more and more, like take a big breath, then you're mixing as much as 3,100 milliliters with the 1,000. And so that's one of the added benefits of taking larger breaths, is because you do, one real advantage to those big breaths is that you're mixing in now, instead of 500 mixed into about 1,000, you mix in maybe 3,000 with 1,000. And so you're always dealing and trying to overcome that residual volume. Because you can't collapse your bronchi, you can't collapse your trachea, you cannot get that last bit of air out, but it's not a small trivial amount, it's actually quite a bit. So that's it for the volumes. For the capacities, so vital capacity is our first one. That's the most important one. It's the one that you'll actually measure. This is the maximum air you could ever breathe out of your lungs, is one way to think of it. So if we walk through here, and I'll just act this out. So tidal breathing, as far as I can go. In as far as I can go, but then back down to normal. In as far as I can go. And then out as far as I can go. That's your vital capacity from peak to trough. So you have to first breathe in, inflate all the way, and then you don't just breathe that out. That's what our inspiratory reserve was. You actually don't forcibly expire. You just get back down to normal. The vital capacity, you go all the way in, and then you force it all the way out, all the way down to the bottom. So this entire purple arrow represents the vital capacity. And as you can see here, it's just IRV, or inspiratory reserve, plus tidal volume, plus expiratory reserve. And so you have 4,800 as your normal vital capacity. Again, this will vary based on body size. And this one actually, your vital capacity is also pretty predictive of your age. And so the older you get, you just sort of stair-step down in your vital capacity. You could overcome that by keeping the muscles of breathing a little bit better in shape, but it still tends to decrease with age. And just to give you an idea of the biggest I've ever measured in this class was 700 milliliters. So it can get up higher than 4,800. So our next one, and one thing to point out before I go over the other capacities is that when it says capacity, that means it's a combination of other measurements. So you always you can add things together to find out someone's capacity, no matter which one it is. That's why they're called capacities rather than volumes. You don't have to. You can directly measure vital capacity by just having someone take as big a breath in as possible and then blow all the air out. You could measure it as a single volume, but you could also measure individual volumes and then just add them together. So inspiratory capacity, if you just take a look at that arrow, it's pretty close to inspiratory reserve, but you're just including that tidal volume in it. So tidal volume plus IRV equals your inspiratory capacity. And then total lung capacity, you look at that arrow, it's the whole chart. So this is your vital capacity, but add to the vital capacity the residual volume. This one you'll never measure in a clinical setting. You cannot easily figure out the precise number for the residual volume without breathing in a special kind of air. So you can do this, that's how they figure this stuff out, but basically you breathe in a gas that has a little dye in it that is of a known concentration, and you breathe it in, and then it dilutes in your lungs, and you breathe it out, and you can tell how big your lungs are based on how diluted the dye is. The bigger your lungs are, the more diluted the dye would be. And so you have to use, it's not really an invasive process, just a little bit more complicated to figure out what someone's residual volume is. So that's one that you probably won't be measuring that often. And functional residual capacity, you won't be dealing with, so we won't be covering or giving any basic numbers for that. But you can see basically what it is. It's your expiratory reserve volume plus your residual volume. So those are the volumes. So I want you guys to be able to, if I give you, inspiratory reserve and tidal volume and vital capacity, if I give you the numbers for those, I'd expect you to be able to calculate expiratory reserve volume. So just the basic math of it. So bring a calculator if you feel like it. I'll try to choose very round numbers so that the math is relatively easy. But make sure you guys can do that so those equations aren't just there for fun. I'm going to ask you guys to just do that kind of thinking. Try to think if someone has it. If you know their inspiratory reserve and their tidal volume and their vital capacity, you can calculate that expiratory reserve volume. And make sure you can read one of these, because I might just give you a chart to interpret it. I won't ask you to write me an essay about it. It's a little harder to write essays about inspiratory reserve. So make sure you can read a chart like that, because there's a good chance you'll see one next week. So there's the adult male averages again. You can know them all. You can take a look at their differences. That's your big one. It's these reserve volumes. But again, because these aren't corrected for size, they over-represent the difference in volumes. If you were to take evenly sized women and evenly sized men, there would be only a slight difference. It would not be nearly as drastic as what you see here. And men tend to be less healthy when aging, so in a clinical situation, women's lungs are probably going to be working better anyway. So that one's straight from your book. All right, so our last topic is probably the harder one because it involves quite a bit of chemistry. There are only 4 terms. Oh, sorry, I'm jumping ahead. Skipped. I guess there's not a picture for this one, but let's talk about expiratory volume measurement. There are 2 different measurements. Your lab manual talks about these in depth. I recommend that you guys read through that. These are important in that they are the 2 measurements that will show you whether or not someone has restrictive diseases, a restrictive disease or an obstructive disease. So before we talk about forced vital capacity and forced expiratory volume, let's talk about obstructive versus restrictive. So an obstructive, see, these are all issues with getting air in and out of the lungs, but they're different than each other. You can have both of these at the same time, many people do. But an obstructive disorder, like chronic obstructive pulmonary disease, is when you have something impeding the flow of air coming into the lungs. So it's like a traffic jam or a bottleneck, sort of, in the air flowing in. It does not affect your vital capacity. You can still breathe in just as much air if you have an obstructive disorder, but you won't be able to breathe it in as quickly. So that's the subtle difference. So think about that. Think about like if you were breathing through a straw. It would not affect the volume of air you could breathe. You could still, the volume chart we were looking at before, those would all be the same, but it would take you longer. Because because you got to move it through a little teeny hole. So that's what you should think of breathing through a straw as kind of the analogy of any kind of obstructive disorder. And so again, you're not going to use volume measurements to pick that out because someone's volumes could potentially be totally normal. Whereas a restrictive disorder is one that does decrease the volume in the lungs. Or it can decrease the volume in the lungs, or it could simply decrease your ability to fill your lungs fully. So paralysis of the diaphragm or something like that. Your lung volume's still there, but you're not going to be able to fill your lungs. And so for those ones, for restrictive diseases and disorders, those will show up in volume measurements because you'll have way less inspiratory reserve volume. And so your total vital capacity will go down. So that's for restrictive, whereas obstructive is simply going to affect the rate. So that's where we come back to these two different measurements. Forced vital capacity is what we're going to use to detect or to help diagnose a restrictive disease. And so forced vital capacity is basically just the clinical version of vital capacity. You do ask the patient to blow it out as hard as they can because you want it to come out in a reasonable amount of time, because if someone can't, if it takes someone like 3 minutes to blow out all their air, it's not going to be very useful even if they can do it. And so it is still forced, but it's basically just a measurement of vital capacity. So these are mostly done digitally now. So they know based on the flow of air and the diameter of the tube you're breathing through, they know how much volume, roughly how much volume of air you've blown out. So that's your forced vital capacity. And then forced expiratory volume, or often abbreviated FEV, that's the cool one, because that's the one that you must have in order to diagnose obstructive diseases, because this is the only measurement that we talk about this week and that is really used that can take into account how quickly you can breathe. So this one doesn't take into account the volume. It's not interested in the volume. It measures the volume, but that's not the point. The point of forced expiratory volume, and in your book, it has, so it's often generally abbreviated as FEV. But that's a little misleading because in every case I've ever seen it, it's FEV, and in your book it says sub-T, and that means time. Because it's your forced expiratory volume, but it's going to ding you if you can't do it quickly. And you're going to score better if you can get that volume out faster. And so the most commonly measured one is FEV1. And this is 1 second. Usually they don't necessarily write the second there, but just so you know. It's your forced expiratory volume in 1 second. How much of your vital capacity can you get out in 1 second? That's what this is answering. So I'll say that again. So the whole point of FEV1 is to see how much of your vital capacity you can get out in 1 second. Because remember, these are for restrictive diseases, so that's the straw analogy. So if you're perfectly healthy, everyone in this room grabs a straw, puts it in their mouth, and tries to blow their vital capacity out as fast as they can, they're not going to get it all out in 1 second. So it's some proportion of your vital capacity that everyone can get out in 1 second. The norm is 75 to 85% of your vital capacity that you can get out in 1 second. That would be normal, healthy individual. Anything below 60% is the main criterion for diagnosing chronic obstructive pulmonary disease. And so that's why these ones are important. You're going to see this. You're going to see how far something has progressed by how crappy that number is. 60% is a hard cutoff. Anything below that, that's a serious issue. Anything above that, if it's trailing down, that's not a good thing either. But if you're at 75 to 85, that's very normal. All right, so those are those two measurements. So even though there's 2 bullet points on your sheet, there's really 4 things there: restrictive and obstructive diseases, and FEV1, and forced vital capacity. All right, so let's get on to this picture. So this is from your lab manual. On the last picture, it might help if you pull it out, because you may be able to see it better out of your book. Make this a little bigger for us. Because this is something that is going to take, there's other writing up there. It's going to take a little bit of time to just sort of get used to. But right now, try to dig around in your memory and remember what the bicarbonate buffering equation is. I think you guys got it introduced last night, right? Or you guys the night or the morning? Night. I was going to say, you just feel like the night crowd, right?
It was the week before, but yeah.
It was a week before?
First day.
2 weeks ago, so you've already forgotten it? Just kidding. So you guys have already dealt with this equation. And the chemistry of it, even though it's the part that's a stumbling block for two reasons. One, chemistry's weird in that it illustrates things mathematically, but it does a horrible job of telling you what happens first and what happens second. And so one of the reasons that chemistry is really hard to teach is that chemistry, all the things that are illustrated are usually just constantly going on, so there is really no beginning of the story or end of the story. So when it comes to this type of cell biology where chemistry is mixed in, I encourage you to decide what is the beginning of your story. And so for me, the beginning of the story of what's going on here starts here, at CO2 production of the cells. But it doesn't have to, and that may not be that intuitive to you. And so it's one of those things that if it's really not jiving, try to see if someone else tells the story from a different beginning or end point. Because there is no true beginning, you're just picking one. But we learn a lot better when it's kind of some kind of a story, so that there's a first thing that happens, a second thing that happens, and a third thing that happens. But in reality, in chemistry, it doesn't work that way. Everything's happening at once, and so that's one of the things that makes things challenging. That's number one. Number two that makes things challenging is that we're dealing with acids and bases. So we have the most difficult to verbally describe thing ever, which is that an increase in pH is more basic, and low pH is more acidic, and the more hydrogen ions I add to something, the lower the pH. It's craziness, right? We've gone over this if you're in my 112 class, but it's a very counterintuitive thing, so take your time when you're explaining it to yourself. You could learn the whole thing backwards if you just misinterpret what I mean when I say low pH. I mean acidic, and I mean that there's more hydrogen ions. And that's hard. It takes years to really get good at that. Like, that sentence was hard for me to say. It's that hard. So make sure you focus on that and take your time on it. So that's what makes this especially difficult. So you guys have already talked about carbonic anhydrase, right? Mm-hmm. Why do we need it? This doesn't necessarily have a great answer, but I want to hear what you guys have to say. Why do we need carbonic anhydrase?
Because it catalyzes the conversion of carbon dioxide and water into carbonic acid.
That sounds like what it does, not why we need it.
Well, that's why you need it, because otherwise you're not going to be able to transport as much carbon dioxide.
You're not going to be able to transport as much carbon dioxide. That's a good point. So you want to be able to efficiently move carbon dioxide. This is not an oxygen story. This is a carbon dioxide story. Now, oxygen matters in this story, and we'll talk kind of about this huge dump off of oxygen and why hemoglobin makes a whole lot of sense to work the way that it does. But let's start up at the top here, and don't forget the little edges of this illustration. CO2 is carried a lot of different ways. CO2 is incredibly convenient. There's a reason we carbonate beverages with it. It's because it dissolves really easily in water. So CO2 is found just as a dissolved carbon dioxide molecule in our blood. There's not a ton of it that way. It's not the majority, but it is significant. The width of the line represents the relative proportion of how we carry CO2. And so the majority of it is what you guys probably focused on in lecture and what we're probably going to spend the most time talking about today. But the second most common way is just CO2 actually binding to hemoglobin itself, creating carbaminohemoglobin. And that allows us to, again, carry more CO2. And the goal with CO2 is to get rid of it. We want to take it to the lungs. So it's nice to have all these different pathways, but dissolving CO2 is definitely an option. But the skinniest arrow, this chemical reaction, is the same as this chemical reaction. It's the exact same thing with two big differences. One of them's in the plasma, one of them's on a red blood cell. And the second big difference is that one of them's slow and one of them's fast because of carbonic anhydrase. Now, the one out here is actually pretty problematic because this is going to happen no matter what. If you have CO2 and water together and you give it a little bit of time, it will turn into an acid, which then turns into our friend bicarbonate, which also, when you create bicarbonate from carbonic acid, you have to create a proton. And if this happens out in the plasma, that's the end of that story. It's a really simple story. Start with CO2, end with hydrogen ions. So CO2 production equals acidity. Does that make sense? That's the easy kind of first step. That's why it's good to start with what goes on in the plasma. Now, there's other reasons that you become acidic during a high metabolic activity, though. So it's not just CO2. You're producing other things that lower the pH. So this pH problem is not just CO2, but in this case, we're talking just about what CO2 does. Now, a real nice way to carry CO2 is by these big, expensive, fancy things full of hemoglobin, which are our red blood cells. So in this case, same exact chemical reaction, but with a really cool adaptation. You've got carbonic anhydrase, which makes that reaction happen like 180,000 times faster, like not even exaggerating. It's that much faster. So this thing basically, it's so much slower than this. So this happens instantaneously. The conversion of CO2 and water to carbonic acid, which, like acids do, dissociate into our bicarbonate and our hydrogen ion. Same thing. Here's where the fanciness comes in. We ship the bicarbonate out into the plasma. And that's a super cool thing to do when you're an organism that often has to deal with hydrogen ions floating around in its blood. So that hydrogen ion is going to cause problems. It's going to lower the pH. But as long as you've got red blood cells around and you're not producing a crazy high amount of CO2, so like most of us sitting in the room, we're not going to fatigue, we're not going to burn, we're not going to have damage to our tissue, because that hydrogen ion can be dealt with by this weak base, which is bicarbonate. So I remember when I first thought of this, I'm like, wait a second, why is bicarbonate even good to produce if every time you make bicarbonate, you also produce a hydrogen ion? That doesn't sound like it helps at all, right? Did anybody else have that occur when you look into this problem, look into this equation? Well, when you separate the hydrogen ion from the bicarbonate, you keep the hydrogen ion in the red blood cell and you ship the bicarbonate out, now you've simply introduced a buffer in the form of bicarbonate into your blood. And so you're going to help your body deal with low pH by shipping that weak base out there and keeping the hydrogen ion stuck to the red blood cell. So this hydrogen ion gets stuck to the hemoglobin. And you guys talk about what it does to hemoglobin? So it changes hemoglobin. So hemoglobin is made of it's just a protein, big fancy protein. Like any other protein, it can denature, and one of the strongest thing that can denature anything besides heat is acid. And so this hydrogen ion basically binds, it doesn't have like a receptor in the hemoglobin, it just denatures it. It gets stuck to it and actually makes hemoglobin worse at carrying oxygen. But that makes a lot of sense because we're at the tissues. So when CO2 comes in, it results in a hydrogen ion being produced, which sort of breaks hemoglobin a little bit and allows it to more easily dump off oxygen. That's called the Bohr shift in the hemoglobin loading curve. And so you guys talk about the loading curve yet? It's a fancy curve. Pretty useful to illustrate this stuff. We might get to it next week. Or with the kidneys, we have to talk about it, so it'll come up there. Let me know if you have any questions about that. It's a really useful tool to be able to sketch on an exam if you can recreate it appropriately. But that's our second benefit that we didn't talk about yet for carbonic anhydrase. This reaction needs to be fast so that basically the second that CO2 comes into a red blood cell, it dumps oxygen. If the carbonic anhydrase isn't there, CO2 is still going to come into the red blood cell. It's still going to have that slow reaction happen. But by the time the hydrogen ion is produced and the hemoglobin with hydrogen ion the hydrogen ion binds to the hemoglobin, the red blood cell's out of the capillary bed already. It's gone. It's missed its opportunity to dump oxygen in the one place you need it. And so this is a really cool adaptation. Where you produce CO2, you break hemoglobin a little bit to dump oxygen right there, just like the picture illustrates. Like it happens instantaneously. Without carbonic anhydrase, you'd have a delay and it would be useless. You'd get rid of the CO2, but you wouldn't bring oxygen to the right areas of the body. You would be oxygenating like your veins or something, or maybe even it wouldn't happen until it got back to the lungs. It wouldn't work very well. So that's kind of that connection between CO2 coming in, why we need the speed, and its effect on oxygen offloading And that's a really nice way that we use the red blood cell. It's one of the ways it's really useful. Yeah.
Can you say that one more time? So the hydrogen ion binds to the hemoglobin.
Mm-hmm.
The hemoglobin hates that,
Yep.
so it dumps its oxygen.
It makes it even easier to dump the oxygen. Yeah, it can no longer easily hold on to, each hemoglobin molecule has 4 oxygens. The last one, hemoglobin has the weakest grip on it, and so this hydrogen ion sort of tickles it and it lets go. Can't hold on anymore.
And the carbonic anhydrase is used for both of those reactions, both of those arrows in there?
For which arrow? This one right here is the only place. Where's the other arrow you're talking about? This one?
After that, yeah.
No, so this is going to happen on its own. So this carbonic anhydrase, this reaction up here is so slow that it's useless to us if we don't have the carbonic anhydrase. This weak acid will be produced on its own. It does not happen as fast as that, but it's still fast enough that this process functions well for us. The other thing that the red blood cell does is, again, separate the bicarbonate from the hydrogen ion, and therefore providing added buffer in our blood when we have CO2. Another awesome thing to do, right? So now you dump, not only do you dump oxygen right at the tissue that's active, but you also dump bicarbonate, so you can buffer out any acids that are produced from those active tissues. And so it's a really slick mechanism. Yeah.
Is the carbonic anhydrase used again on the other, when you reverse that, at the lungs?
Always goes both ways.
Right.
Yeah, so everything we see here and in the next picture, you just flip the arrows around to understand what's going on in the lungs, and it works just as well going the other direction. All that matters is the concentration. It goes this way when you got a lot of CO2, but then when you get to the lungs, you hopefully have low CO2 in your lungs, so everything flips around. Last thing I want to mention is, for this picture, is the chloride shift. So the chloride shift is what you have to do. You're shipping out negative charges from the cell, and you can't just, sorry, let me point so you guys know what I'm talking about. You're shipping out negative charges from the cell in the form of bicarbonate. You can't do that without creating an electrochemical imbalance, and that's not good when it gets too extreme. So every time you send out one bicarbonate, you ship in a chloride. And so this is an importance of adequate chloride levels in the blood, is that chloride for the most part it's used a lot, but it's not like something you worry about killing people with. It doesn't come up that much. But this is a pretty important reason to have enough chloride in your blood. Because if you don't, you won't be able to ship out the bicarbonate and you won't be able to buffer your blood. So you'll have this metabolic acidosis, which is just when your blood becomes too acidic. And that can actually happen from chloride imbalances, not just active tissue. So your tissue could be relaxed, everything good, but you don't have enough chloride, you won't be able to buffer your blood nearly as well. So let's take a brief look at what happens in the lungs just to connect the similarities in what we're seeing here. So the other image, your book does not have this image. At least my version of the book doesn't. And this is just going to look really similar, but all the arrows are going the other direction. Still have a chloride shift, but it's going the other direction. So now we're at the lungs. Now we're in a totally different environment. If you're adequately breathing in this area of the lungs, you have low CO2 and you have high oxygen. So now the driving force is going towards the red blood cell for oxygen and away from the red blood cell for CO2, which is the opposite of what it's like at the tissues. So as long as you're breathing frequently and keeping the CO2 low and the oxygen high, this is going to happen very, very efficiently. So now, here's our carbonic anhydrase going the opposite direction. All the arrows are going the opposite direction. So if we start from our HHB here, our hemoglobin with hydrogen bound to it, when oxygen gets forced on, it's actually going to kick off that hydrogen. The high oxygen level forces the oxygen back on the hemoglobin, which kicks off the free hydrogen ion. That hydrogen ion is going to come and meet up with the bicarbonate that's now been pulled back into the red blood cell. The hydrogen ion and the bicarbonate will combine together to form carbonic acid. Carbonic acid will be converted back to CO2, and you get rid of CO2. So when we say we carry most of our CO2 as bicarbonate, That's really where this CO2 came from in this picture, and it's where it went in the other one. Before, these arrows were going this way, and the CO2 essentially went from being CO2 here to being CO3 there, but those are the same carbon and oxygen molecules. So that's why when you say we carry most of our CO2 as bicarbonate, that's why. We send it out into the blood, free in the plasma as bicarbonate, and then we suck it back in at the lungs and get rid of it as CO2. So we're never breathing out bicarbonate. I'm not going to do that, I hope. We're usually breathing out a gas form of CO2 that very easily diffuses because it dissolves in water really well. And notice all the other things reverse directions too. So oxygen can be dissolved in the plasma. It's a really small amount because oxygen doesn't dissolve very well. And we still have CO2 passively moving out without any fancy conversion. And we still have our slow conversion of CO2 back this way. So the last thing I'll mention on this picture is that dissolved CO2, take a look at those arrows. Dissolved oxygen. Very small amount of oxygen in the plasma. It's virtually useless in our plasma in most situations. However, there are hyperbaric oxygenation chambers that can be used to force oxygen into the plasma when for some reason the red blood cell can't get to the destination to deliver oxygen. And there are a couple big examples of when that happens. Mostly it happens in long capillary beds. So in capillary beds, as I've drawn them before, if this is a capillary, red blood cells in normal people are about that big. They squeeze through there. They stack on top of each other. Usually they're not spaced like this. Usually they actually compress and kind of stack on top of each other. They sort of draft on the way through. That's one of the reasons they have the shape that they do, so they will actually stick together in columns. But if something happens to a red blood cell to make it larger, like high glucose levels or something like that, that's one of the things that also affects hemoglobin is high glucose levels. These will actually increase in diameter so much that they'll ricochet off the sides of capillary beds, sometimes in long capillary beds like the ones in your kidneys or in the colder areas of your body, like your feet. They'll actually get stuck there. And the only thing that can get through, they don't form a perfect block, but basically it's just a bunch of congestion of red blood cells. Only thing that can get through is plasma. So if you're trying to deliver oxygen to this cell, in this situation, the only way you can do it is by dissolving oxygen into the plasma. And so that's when the dissolved oxygen does matter, is when you have anything obstructing capillary blood flow. Normally, in someone with diabetes, in later stages of it, you're going to get tissue death. Usually neurons die first because neurons, they suck. They just die. They don't tolerate imbalances very well, and so that's why you'll get neuropathies in people with diabetes. And one way to help some of these people or other individuals it happens in burns too, because burns can ruin the blood flow, so only plasma comes back into the healing tissue. So if you are in a room with 100% oxygen, that's 5 times more oxygen than is in the atmosphere. And the idea behind that is you're going to help those tissues heal by having high levels of oxygen. It needs to be monitored really closely though, because once you get above 2 atmospheres of oxygen, you run into issues with oxygen toxicity, because oxygen, it's great for making energy, but it also rips electrons off everything. And so it's something that shouldn't be used recreationally above normal atmospheric pressure. All right, so that's pretty much all I want to talk about. Any questions about this process? Yeah.
When you have a low RBC count,
Mhm.
does more CO2 dissolve into the plasma, or does it stay in your tissues?
It's going to leave your tissues no matter what, because it's just the concentration gradient in the previous picture. So